des nôtres ce matin. Sam Shah, je me tourne vers vous pour entamer cette discussion. Le constat que je dressais tout à l'heure, avec, je ne vais pas citer tous les chiffres, mais les chiffres sont vraiment évidents, cette chute de la téléconsultation, cette chute des usages digitaux qui a suivi le Covid, qui est valable pour la France. Est-ce que vous le partagez également de l'autre côté de la Manche ou dans les autres pays d'ailleurs dans lesquels vous intervenez un peu partout dans le monde?
Good morning, and thank you for inviting me. I'm sorry I'm not speaking to you in French, but hopefully you'll be able to understand some of what I say. So I think we're seeing this trend not only in France, but across the whole of the world, where there's been some regression back to consulting in a way that took place before COVID was around. Some of that is due to habit, but some of it's also due to why the consultations digitally increased during the COVID period and after. And it goes back to need. There was necessity during the time of COVID. It was a matter of life and death in many cases. And so the risk balance changed. The reasons that people consulted through teleconsultation and were accepting of it changed. Physician habits also changed during that time. And certainly if we look at places like the UK, and it's probably not dissimilar in Europe, in France, elsewhere, there's also the political dimension. Certainly in the UK, there was a strong, almost media-driven political position against the physicians that were consulting remotely, almost creating a public mood against remote and teleconsultations. That was one part. The second part that we've seen in this change is also the funding and reimbursement model. It still hasn't changed in many parts of the world. If we look at Germany, for example, there's still a strong bias towards consulting in person over consulting online. And even in places like the UK, there's still some preference for patients to be seen in person. And then we also have the regulatory model. It hasn't really evolved. We're seeing this not only in the UK, also in the US, in other parts of the world, where the regulatory model is still designed around a physical model of consultation. So if we look back to the COVID period, there was almost a 300% increase in teleconsultations during COVID compared to before. But it was driven by those factors: necessity, the payment model, and the easing of regulation. And I suspect in France there are some similarities, probably not all of the same, but some similarities there. The other part we have to look at is the friction for the patient. We might do some of these things online, but not all of it. So then we get to the question around, well, what's the point? If the user experience end to end hasn't been solved, if the patient still has to go in person for a blood test, to go and pick up their medication, to go and see someone for whether it's some diagnostic, then we ask the question, well, what's the point in having part of it through a teleconsult model, but not all of it? So these are some of the factors that both driven the change during COVID, but has also now seen us regress back to the pre-COVID period.
C'est intéressant cette analyse que vous nous proposez en nous disant que dans une période exceptionnelle, on ne connaissait pas cette maladie, on était véritablement sur des risques mortels, on était entre la vie et la mort. Et à ce moment-là, le cadre dans lequel on exerce disparaît, explose, et le champ des possibles devient beaucoup plus important, d'où cette explosion de la téléconsultation et d'autres suivis que l'on appelait dans ces lieux-là depuis 10, 15 ans, justement. Et aujourd'hui, vous nous dites que ce risque de vie et de mort n'est plus là. Donc finalement, le système, c'est au retour au business as usual. On revient aux vieilles habitudes. Pourtant, notre système reste dégradé. L'accès à des médecins reste compliqué. Les hôpitaux sont totalement sous tension. Les services d'urgence sont en train de fermer à peu près partout de manière permanente, semi-permanente, d'abord les nuits, puis les week-ends, et puis ensuite un petit peu plus. Enfin, excusez-moi, mais en tant que citoyen et malade potentiel, j'ai quand même l'impression que le risque de vie et de mort reste là, et pourtant on ne peut plus aller aussi loin dans l'expérimentation numérique.
So one of the things is the immediacy. During COVID, there was this immediacy where everyone was worried about the risk of transmission. They were worried about the immediate risks of COVID. problem now is we have inequity in access to healthcare that's very obvious, but it doesn't pose the same immediacy that we saw during COVID. So this risk exists at a system level. We don't have enough hospitals, we don't have enough workforce, we don't have enough beds in many places. And access is a problem. We all recognize that. The other challenge that comes alongside that is perhaps some of the ingrained ways in which clinicians, physicians, nurses work. Many people will be used to working in a certain way and may not want to change. They might be used to operating in a way that is a physical model of care. Now, it might be easy to say, well, that's entirely the fault of the physicians. But we have to almost look deeper. Why are people reluctant to change, and what is it? Well, one of the factors is we are probably more in control of our environment as clinicians when we're used to seeing patients in a certain way with access to diagnostic tests, tools in front of us with the patient. There's also the digital literacy of the clinical community that hasn't really evolved in the way that it should. But most importantly is the design of systems and services. Historically, digital systems are never really designed from the perspective of the user. Often they are overlaid by grand statements onto systems, sometimes political statements of we're going to get a certain number of people online without thinking about the design of the system for the clinician or the patient that is beneath that. So clinicians might want to change, but the environment they're operating in isn't always right for them, hasn't been designed for them in mind. For patients, though, it's even more important than this. They've got a massive set of needs that are not being fulfilled by the design of our systems across Europe, whether that's in France, whether that happens to be in a place like the UK. They've not been designed around the end-to-end needs of the patient in mind. And this causes friction between the clinician and the patient, friction between the patient and regulators that design the regulatory model. So if we're really going to see the growth and evolution of digital health to solve problems, the solutions have to be designed around the user. And right now, we're not seeing that. Right now, we see difficult EHR systems for clinicians to work in. They end up having a relationship with the computer, not with the patient in front of them. The way in which we push a patient through the system is designed around the system's needs, not around the needs of the patient. We don't make it easy enough. And then we take other things, like basic things, like medication. Across Europe, we might have harmonization on prescribing, but it's impossible to get harmonization on dispensing the medication remotely to a patient. So these things have to be solved. And then even remote diagnostics. There's almost a view which is against patients accessing diagnostics themselves. Here in France, it's still better. But in places like the UK, it's pretty poor, where there's a negative view to patients electing to access diagnostics themselves. So the model of care and where the power base is needs to shift.
On comprend, et on va en parler bien sûr, ce sera une des questions centrales de cette table ronde sur ces freins culturels. On voit bien que le frein, il n'est pas technique, le frein, il n'est pas informatique, le frein, il est culturel, et vous le dites aussi bien, en renvoyant dos à dos la responsabilité chez les soignants comme chez les patients. On va écouter les patients dans quelques secondes, mais j'ai une question, elle pourra vous sembler idiote, mais après tout, est-ce qu'on ne peut pas forcer le système à changer ? Aujourd'hui, au moins si vous habitez en France, sur les impôts, vous n'avez plus de choix. La déclaration, elle est en ligne. Et je peux vous assurer que le système n'est pas du tout designé pour les utilisateurs. Mais vous n'avez pas le choix. La déclaration d'impôt se fait en ligne. Je ne vous parle même pas de la déclaration immobilière qui vient de nous sortir. Alors là, le design, il est encore un peu plus abominable, mais on n'a pas le choix. La plupart des services publics, y compris la justice, ont été des services qui sont digitalisés. Les services privés, acheter aujourd'hui un billet d'avion, n'importe quoi, on est en digital. On est en digital aussi. Essayez de faire une carte d'identité, vous n'en avez pas en Angleterre, mais essayez un jour d'en faire une en France, vous allez voir quel est le parcours du combattant, mais on a imposé que tout cela soit digitalisé. Est-ce que pour la santé, à un moment, on ne peut pas imposer aux patients et aux soignants un parcours digital ?
I mean, look, that's one way we could solve the problem. We could just force people to do it. But like everything, people will find workarounds. If any of us are forced to do anything, we'll find a way around it, and not necessarily the right way around it. But bigger than that is, what about all the people that will never be digital? Approximately 12% of the population at any one time is digitally disengaged. So if we look at internet penetration around the world, it's really high in some places. In the Middle East, it's 99% in the UAE, in the United Arab Emirates. If we look at places like the UK, it's 94%, the US is 95%, France, Germany is a little bit lower because the geography is so much bigger with rurality, so digital penetration is a little bit lower. But that still means a big part of the population has access to the internet, so they might be online. But then we look at the other side of the population, this 12%, digitally disengaged. They won't do anything online. They don't have access to a computer or a smart device. They may not have access to the internet. They can't afford it. And so if we force everyone, there's a responsibility on governments to put the infrastructure in place, the training in place, the systems in place. But even that's not going to solve it. And then there's the human element of care. Not everything can be digitized. So we have to accept that it's going to have to be a hybrid model based around the needs of the patient, often deemed between the patient and the clinician. The clinician and the patient have to have an interaction to work out what's right for them. And what's right in an emergency situation will be different to what's right in an urgent situation. That will be different to a routine primary care consultation, which might be different to a chronic condition or something like that. And so we have to recognize that it's not a one-size-fits-all model. And even geographically it will vary. In very rural areas, actually connectivity might be really poor, a little bit like some parts of this region. It's impossible for me to get a 4G or a 5G signal. Well, with that in mind, I can't force everyone to go digital. So yes, going digital and making it compulsory would be an interesting move, but it comes with commitment, investment, infrastructure, major programs, and we know governments are really bad at this. They'll make grand statements, they'll make political statements, but will they ever deliver? Highly unlikely.
Avant de passer la parole à Arthur, Denis.